I'm Dr. Kim Curseen. I'm currently outpatient director of supportive and palliative care for Emory School of Medicine. So I actually help direct a palliative care clinic for Emory Healthcare here in Atlanta, Georgia. And I'm certified in internal medicine, geriatrics, and palliative care, but I've worked in the field for a long time, and I was also a hospice medical director for a number of years. Unfortunately, I have no relevant faculty disclosures. So I figured the way your lectures have been broken up, they've been broken up in subtopics. So we're going to be talking first about prognostication. Then we're going to be moving on to managing the dying patient, looking at the interdisciplinary team, symptom management, and caregiver needs. Because when you think of end-of-life care, these are going to be all the components that you're going to need to provide good, competent care. So the objectives, I would like you to be able to define end-of-life care, because sometimes that's difficult. Patients and families will ask you exactly what that is. And it can be a kind of a nebulous concept to conceive of. Distinguish the phases of dying. So you actually recognize when your patient's dying. You think that you would know, but sometimes it can be elusive. You'll be able to evaluate physical and emotional symptoms of the actively dying patient. If you can evaluate them, that means you'll be able to treat them, and you'll be able to provide competent family support for people who are dying as well as their families. So I always like to make sure that we're discussing the same definition. So how we define palliative care. Palliative care is a medical subspecialty that specializes in the care of people living with serious illness. It focuses on providing relief from the symptoms and stress of serious illness, whatever the diagnosis, and the goal is to improve quality of life for both the patient and the family. It's provided by a team of specialists who work together with a patient's doctors to provide an extra layer of support, and it's appropriate at any age and any stage of serious illness, and provided along with curative treatment. So, one of the things we realized in the definition of palliative care, what you don't see here is you don't see the word dying. And so I like to explain that palliative care is the kind of care that people who are seriously ill need, no matter where they are. And there are different vehicles in which you provide the palliative care. So when we look at end-of-life care, end-of-life care is just the provision of palliative care when death is imminent. So I'm often explaining to patients that when you get a serious illness like cancer, in the beginning, you will get your palliative and supportive care, your symptom management, your spiritual support, your social support, your extra layer of support. You might receive that through my clinics while you're getting aggressive care. If you go into the hospital, then you may see my partners or my counterparts, and you'll get your palliative care there, you'll get that support. However, when the time comes when we are no longer able to cure the illness, and what we are doing is now focusing on the symptoms of the illness, so we're not able to fix the primary problem, but we can certainly impact positively all the things the primary problem is causing, that's when we are then we're going to deliver your palliative care through a vehicle like hospice, or deliver end-of-life care, if that makes sense. So palliative care is the umbrella, and there are different parts. So when we're going to be discussing the part of the palliative care that comes for patients at the end of life. So no good palliative care lecture is complete unless you see this slide. And I'd like to draw your attention to the second diagram, that when patients are first diagnosed, curative treatment, appropriately so, is taking up most of their time. But in a more advanced medical model, it would be ideal for people with serious illness to have palliative care introduced early in the process, because as the illness progresses, if it's an illness that cannot be cured, eventually it's going to come to fruition, or it's going to reach its terminal phase. And once it reaches terminal phase, then palliative care becomes more prominent, and palliative care then starts to be delivered through the vehicle of end-of-life care. So we're trying to figure out where end-of-life care fits in. So let's start with a case. Mr. T has stage 4 lung cancer and end-stage kidney disease. In the last 48 hours, he's becoming more confused. He's really short of breath. You're really worried, and you're concerned that further aggressive interventions is likely not going to be able to turn it around. You've been able to help him before, but you sort of see that he's reaching to a different stage. And because you've done all the things that you can think to do, and you see that he's continuing to decline, you decide that it's in his best interest to recommend that we focus on his comfort, which are the symptoms that we can impact now. And you express to the family that you're concerned that he may be dying. The family receives this information of, with the normal way families receive information like this. But they have some very pertinent questions, and they trust you. But they want to know, how do you know he's dying? They want to know what's going to happen. Then they want to know, do you think he can hear us? And they're very concerned because he's been so sick, he's not eating and drinking, and they're fine with him being kept comfortable, but how are we going to see him? All which are very valid questions. So let's start with prognostication. How do you know if somebody's close to the end of life, right? How do you know he's dying? And we get this question all the time. Well, many of you probably give other palliative care lectures have seen a slide similar to this. When you think about how your serious illnesses such as end organ failure, dementia and frailty, and cancer progress to death, they all have different trajectories. So starting with cancer, the one at the top, most of the time if you get diagnosed with cancer, you sort of feel the same way you did before you had cancer. So the doctor tells you you don't physically feel any different, and you go through, you get treatment. You may feel bad with treatment, but you're kind of moving along. And your functional level, there's possibility that it can stay fairly high. However, there comes a point when the cancer starts to progress and it takes over. Then once you start a decline, the decline is fairly straight down. There's very few times where you just sort of swing back up. That once you're dying of cancer or that process has started, it continues on, and there's a clear trajectory to death. And many times most people can kind of conceive of this. This makes sense to people and to the patients and families and physicians. We move to others, like heart failure and lung failure. They're probably going to see you at a lower functional level, so they already know they're kind of sick. They know they're sick. By the time, if your heart's doing fine, you don't know you have heart disease because you're out there living your life. By the time you figure out you have heart disease and you feel bad with it, your functional level is low, and you're already on your decline. The problem with heart and lung failure is that you have your decline, but you have these very sharp dips. And in each part of these sharp dips, you could have an incidence that could possibly be fatal, or you can recover and go back to your baseline. So what's hard about this is that it can be difficult to prognosticate, because for families, they say, well, yes, he was sick and you saved him before, so what makes you think that you can't save him now? What's the difference between here and here? Which can make them sometimes want more aggressive therapy, even when it's concerning that it may not be appropriate. And then you have what we call the prolonged dwindling, which are frail patients with dementia, maybe patients that have late-stage strokes that have stabilized. They come to you with very low functioning levels, but the time that it takes, if nothing catastrophic happens, the decline is so slow that people can become kind of complacent, and so when death is near, their functional level is so low, it can be difficult for family members to sort of understand, well, mom has been bedbound for years, I've been feeding her for years, why is this time different? Why can't you fix her again? So thinking about prognostication, what are going to be the components of prognosis? What is the family asking you for? They're asking you to sort of foresee and foretell the future, which is incredibly hard. It's a big, daunting task. So I want to kind of break this down a little bit, because this is going to be very important when you are talking about end-of-life care. And I apologize for the phone ringing. I don't know who's calling me. The five Ds of prognostication. What is, you know, when people are asking you what's going to happen, or asking you to prognosticate, what are they actually asking for? Because there's certain things they need to know. And I'm pretty sure you've all had patients where they've had a serious illness and you ask them, what has the doctor told you? And they say nothing. And they've been in the hospital for the month and you're like, well, it can't be nothing because somebody would have had to tell you. And your counterparts swear, like, no, we've told them every day. Why are they still saying we're not telling them anything? Usually what happens is that on this list of 5 things, we're telling them some of the 5 things, but not all of the 5 things. And unless people know all these 5 things, they don't really feel like they've had an adequate prognosis. So that's sometimes the discrepancy. So what we're going to be focusing of the 5 Ds of prognostication for end-of-life care is disease progression and recurrence, and the idea of death or when death will come. The other 3 are just as important depending on what the patient's going through. So disability, how disabled, how uncomfortable will I be? How much will I suffer, basically? The medications that you're going to give me, how much toxicity am I going to? What are the side effects? And then, very practical, how much will this cost? Where will I be? How will I be cared for? What's going to be my support? How will all of this work? What are the logistics? And so when you're giving a prognosis about you have lung cancer, the major point is you can tell them that you have a prognosis of, you know, your prognosis is less than 5 years, or your prognosis is in days to weeks. But unless they understand what the progression is, how disabled it will be, what medications, how are you going to treat it, and what this is going to logistically look like, they could basically leave saying you didn't actually tell them anything because it wasn't what they needed to know. So when you're thinking about prognostication, so you may have several patients with the same illness, and some are more functional than others, but they may have the same stage of disease. How does your attending go in and say patient in bed A may need end-of-life care or possibly hospice care, versus patient B, we're going to send them home, see them back in a few months, and maybe consider more treatment. How they're making that decision is really based on functional status. And when you think about all scales and all diagnostic scales to tell you how patients are going to do in the future, most of them have a functional component, and most of them depend a lot on functionality. So basically, the more functional you are, the better your prognosis. The less functional you are, the worse your prognosis. So we use here a lot of the Palliative Performance Scale, which has been validated in cancer primarily, but it's been, you know, extrapolated for other serious illnesses. If you have a Palliative Performance Scale of 30, where you are totally bedbound, you're a total care, you're not eating or drinking very well, and you're full, confused, or drowsy, then you have a 60 to 80% prognosis of being of passing away in about 6 months, if that makes sense. So if you're if you're up and you're ambulating and you're working, you have good intake and full level of consciousness, then you're more clinically stable. Your risk of passing in 6 months or less is a lot less. So even if you can't remember what your scales are, if you walk in the house, or if they come to the clinic on a stretcher, their prognosis is bad, or prognosis is poor. So when giving prognosis, it's also important to give ranges. So doctor, how long do I have? So why is this important? Because people need to be able to plan. And I think it's hard for us because when we give this information, there's a lot of anxiety about it because, number one, how do you know we're right? Because nobody knows. We're certainly not God, so how can we say for sure? And so what I explain to patients is when we give you a prognosis, basically what we're telling you is that we are concerned that time may be shorter, and we are saying that it would be really important if there are things that you want to do, you want to accomplish them within this time frame. And our hope is that things will be longer for you and you have much more time, but to be sure to accomplish the important things, let's do it in this time frame. So that's why it's important to give ranges, like hours to days, days to weeks, weeks to months. With the caveat always that you're not sure, but this is your best estimate, and this allows them to plan to make sure that we're covering all the things that are important to them. And many times when you express it like that, because giving a definitive like 3 months, 5 months, 6 months, some patients that motivates them to live every second. Other patients that just has them watching the calendar and having a lot of anxiety, or watching the date pass and they could lose trust in what you say. I had one patient pass their 6-month mark and call me very angry and say, "You told me it would be on this time." So the question is, will giving a terminally ill patient an accurate prognosis result in loss of hope? And this is an interesting question. So studies in the US and the UK have shown that giving prognostic information to patients does not cause hopelessness. However, this is specifically based on culture. It may not be appropriate in all cultures to divulge this information. Generally, patients and families want honesty. So what I say, if you're thinking about your culture and what's culturally appropriate, I say always go with what's culturally appropriate. If you have a patient and you're not sure whether or not they want to receive this information, the best thing to do is to just ask and say, how much would you like to know? Would it be appropriate to talk with you about this in detail, or would you prefer that I speak with your family? If you feel an urgency which to explain, then you can explain, I feel there's some things I'm very concerned about that I think in order to take care of you, you might need to know this information. Is it okay for me to discuss this with you? So it's basically, if you're not sure what they want to know, and this is in any indication, always ask. But there have been studies in the US and UK have shown that it doesn't seem to cause hopelessness when people know what's going on. However, I always explain that if you tell somebody something sad, they're going to be sad about it. That's okay, you didn't do anything wrong. That's just them processing it, but it doesn't mean that they're going to lose hope. But it's okay for people to be sad in the moment, because this can be a sad thing. False optimism can lead to patient and families choosing interventions that they otherwise wouldn't have chosen if they have a realistic prognosis. So this is the other important thing. So if people don't understand what's going on, they'll make choices which might not be in their best interest. But people can only make choices and pick things if they know what's important to pick. So I give this example to my residents. Hey, if I have a turkey sandwich and I have a roast beef sandwich, and I offer you both sandwiches, and you choose the roast beef, and then I get angry with you and say, why did you choose the roast beef? Didn't you know that it was rotten? You're going to say to me, well, Kimberly, why did you offer it to me then? Why is that even on the table if it's rotten? So, people need information in order to make the best choices. And patients don't want information overly optimistic or pessimistic. So they don't want you to walk into the room crying or feeling, and just you discussing gloom or doom. But they don't want you to be overly like, everything's going to be okay. So give your honest opinion in a clear and calm manner. And patients' families benefit from understanding the dying process. Because when their loved ones are dying, most people, especially for people who've never been through it before, may be accepting of the dying process. But the fear and the pushback you get often is because they don't understand the dying process. So being able to explain that and walking people through this journey is really important. Written literature can be helpful. Sometimes we have several books that sort of explain, patient and family brochures that kind of explain what they're going to see at each stage. And families actually use that. They refer that. I've had families highlight the book and bring it to me. And also ask questions from patients and families concerning the dying process, and allow a safe space to ask those questions. You want to be approachable where they feel like they can almost ask you anything. So when you're thinking about prognostication, you have to understand what the phases of dying. So there's a PreActive phase of dying, which usually lasts about 2 weeks. and there's an active phase of dying where it lasts from hours to days. We as physicians are real, and nurses are very good at knowing the active phase of dying. We're not as great as identifying the pre-active phase. So in the pre-active phase, you're probably going to see a lot of restlessness, a lot of agitation, and maybe the beginnings of confusion. If you've had patients who've been in the pre-active phase, they're starting to change positions. They can't really get comfortable. The families might say they're depressed. They don't want to see anybody anymore. So they may withdraw from social activities. They may develop an apathy so that they're not sad or depressed. They're just disconnecting. There are things that interested them, they don't interest them anymore, and they're not upset that it doesn't interest them. It's almost like they're disconnecting from the world a little. They start to acknowledge that they're dying. You know, they may ask you, doctor, am I dying? Or they may never ask you, but they might start planning their death. They might start talking to their children, you know, about things they want or trying to put things in place. You might start to see in patients development of pain or shortness of breath without clear etiologies. You know, they're just more uncomfortable. When they are progressing to the active phase, there are two, in the active phase of death, there are two subs. There's an early and a late phase. In the early phase, alter mental status and neurologic dysfunction. So the confusion starts to deepen, their ability to move. You might see myoclonus or the uncontrolled jerking. You might notice increased sedation, so they're sleeping a lot more. Delirium, a loss of desire for oral intake, and the loss of the ability, they're starting to have loss of ability to handle oral intake. They are becoming more bedbound. You may see increase in pain or shortness of breath. And during this time, organ failure is starting to happen, so their ability to handle the medications that they were using before, you might actually start to notice some toxicity. When they enter into the active phase, which is in the last 24 to 72 hours, they've lost the effective ability to swallow. So these are your loved ones. They're trying to give them sips of water. They're choking. They're closing their mouth. The food's staying in their mouth. They just cannot do it anymore. They have difficulty managing their oral secretions. So this is that loud sound that you hear when patients are dying, or what we call the death rattle. They develop Cheyne-Stokes respirations and long periods of apnea. You might see Kussmaul respirations where they start doing this very deep, low or fast. It can be either slow or fast breathing, but it's different. It's like they're taking these deep breaths almost from their gut each time. The skin starts to change. You may start to notice mottling or livido, and the skin that has patchy, irregular colors. There can be wounds that develop, so you're taking excellent care of your patients, you're turning them, and then you walk in the next morning to your patient, turn them over, and they develop this large wound, and you're like, it's not a lack of care in the actively dying person, it's just that they're experiencing skin failure. Also, the internal temperature in your brain kind of goes haywire, so I'd say all the circuits kind of malfunction, and so you can have wide-ranging fevers, abnormal vital signs, and then coma. So when you're managing a dying patient, so when you think about all those things your patient's going through and all the things the family is going through, this is not usually something that's ideally handled alone. So who's going to help you with this? So if you are able, and I practice in some pretty rural areas, so often my ability to access an interdisciplinary team is low, and I notice the difference in care between the patients who have an interdisciplinary team or the patients who have just me. Much better care when you have a team, because it takes a village to care for the chronically ill and dying. It's almost impossible to serve all of the needs in the room. The physical part we usually take care of. I just find that it's the other parts which are just as important that get neglected when we don't have teams. And all team members are equally and vital importance to make the plan work, because they all bring expertise and skills which are necessary to patient care. So who do you usually have on your team? So a doctor, nurses, social work if it's if it's possible to help arrange with the logistics. Nursing assistants, or people who are actually doing the hands-on caregiving. Spiritual support is incredibly important. Whether a patient is particularly religious, they still may struggle with spiritual issues. Any people who are volunteers, family members in communities, and if you have the luxury of having a pharmacist or people who really understand the medications, or partnering with people who are providing the medications, incredibly important. And bring all these folks together, you can have a really wonderful team. Also in managing and why you need a team is because the patients are going to be going through an emotional process. So there are developmental tasks of dying that people tend to go through, and people who have chaplaincy or spiritual training may be very familiar with this. Often you'll see patients starting to try to work through developing a renewed sense of personhood and meaning. So my life meant this. So like if I'm using myself as an example, I'm a physician now. So my whole identity is wrapped up, my whole meaning is wrapped up in patient care and in this life of being a doctor. And if I become sick and I'm no longer able to do that, then I have to figure out a way to redefine myself and how to find meaning in this new life without something that was so important to me, especially if I'm going to start to make the transition to death. You start to see closures in relationships. People are starting to say goodbye. They're wanting to see relatives they are mend fences in relationships. There can be closures in affairs, just the practical matters, like how I'm going to close out bank accounts, my house, where things are, how I'm going to take care of my family. You might see patients starting to become resigned or accept, and sometimes during acceptance, we may mistake and call it depression when they're starting to socially withdraw. It just means that sometimes they're sad, but sometimes it's like they're not tied to this world anymore, and they're looking to something beyond. And then you see people who have been independent, accepting of the caretaking that they may have resisted before, especially your really independent patients are now allowing people to take care of them. And some patients then in their meaning making start to surrender to the transcendent, where they start to express a sense of awe and meaning, and when they're really delving in and questioning about the afterlife, or even if they're not, thinking of things in a larger way and not so much tied to the details of the world or life. Many of you may be familiar, this is a pretty famous model, the Kubler-Ross model, the 5 stages of grief, and there have been a lot more research to say maybe that we don't have 5 stages, it doesn't quite work this way, it's not linear, but I still think it's important to go through because many patients will go through some version of these stages. It's just not linear, and you can slide back and forth. So when you first hear something difficult, you might actually be in denial, and then you can get angry, and then you might bargain to try to say, well, if I do really good, if I watch my weight, if I eat the right foods, this won't happen. Then you realize, oh my goodness, it's going to happen, and you become sad, and then eventually you become to acceptance. Most people kind of slide back and forth. They might deny, they might bargain, they may be angry, they might accept, and then you come back the next day after you think you have a plan for comfort, and they're like, I want everything done. They slid back, back to denial. But I think it's important to know that this is a fluid process, and it's very normal for people to go around this circle in all different directions, completely normal. And that is just a way of them coping. Eventually, in our hope, for many people, they do work it out. They just need space and time. When you're managing dying, you want to make sure you have the proper setting. And setting is not just where the person physically is, although that's important. Like if you're dying, it's important to understand, where does the patient want to be? Do they want to be in a home environment? Do they feel more comfortable in an institutionalized environment? But ideally, if you have options, can you give them that option they're asking for? And if you cannot, how can you make that environment tolerable with pre-planning? But you don't know until you know what's important to them. Who are the people that are important? You know, when the time comes, who do you want with you? Who needs to be here? Who doesn't need to be here? That's also a good question. What's needed to make the environment more comfortable? What support will be needed to manage the patient's death? So if you know somebody's dying, trying to think about and anticipate, what am I going to need when the time comes? Because the more you can have preset and the more the expectations are set, the easier the process will be, and it will seem less chaotic and seem like a more comfortable death. So you want to have your healthcare providers in place. Caregivers need to know who to call, who are the caregivers who are going to stay. You want to make sure that if you have access to medications, do you have them? How can you access them, and what is your plan to obtain them in the case of an emergency? And if there's any equipment needed, to make sure that the equipment is functioning and working and that you can access it. So now that you've got your setting, now that you've got your team in place, you've got to kind of understand the symptoms. So you want to know, what are you actually looking for? So managing dying physical symptoms. So you want to do a normal evaluation of a patient, but when you're thinking of questioning whether or not your patient's actively dying, you want to see how their swallow is, how their pain, their respiratory status, if they're delirious, if they're having fevers, can they manage their secretions? Because each of these should have active action plans that you're able to pre-plan for, and that you'll be able to make sure your medications are for, and also educate the family that these things are normal. You want to address questions of artificial nutrition and hydration up front. No need to shy away from them. There's some questions that are medical, and there's some questions I put in the category of medical moral. So, does an actively dying patient or a patient nearing the end of life actually need artificial nutrition and hydration? No, they don't. However, because people tie food to love and nurturing, and people tie hydration, not just the idea of remaining hydrated is something that we can do, they will often choose this or want to keep this, even if medically it may not change the outcome. And then often, at least in our country, we offer this as a choice. And I think the reason why we do is so it falls out of the realm of they get to decide to keep this because it provides meaning outside of what it can actually do as far as affecting prognosis. So when addressing issues of artificial nutrition hydration, and we'll come to this, it's important to sort of separate out the part that we're doing for comfort emotionally, and then what we will do when we have to make a medical decision about it. And I will explain that in more detail. And then we have to be thinking about if they have renal failure or kidney failure, how are we adjusting our medications to make sure we're not creating toxicity and suffering at the end of life. Also evaluating for non-physical symptoms. Are they anxious? Are they depressed? Are they having death anxiety? All of these things need to be attended to in order for them to have to be comfortable at the end of life. And then we need to be constantly evaluating for the needs of our caregivers, because if our caregivers aren't in place and they're not doing well, all of our plans fall apart because they all hinge on excellent caregiving. So in pain, you're going to assess for physical and emotional pain. Frequent repositioning. Often patients who are in the active dying phase aren't able to reposition themselves in bed, so sometimes they're complaining of terrible discomfort, and what they needed was not morphine. They needed to be pulled up in the bed. They needed the crease of the sheets gone. So really doing good physical exams every day to make sure what the pain and the etiology is from, and what you can do non-pharmacologically to manage it. The medications, depending on what you have available, opioids and opiates still are the mainstay at the end of life. If those aren't available, there may be access to acetaminophen or paracetamol, ketamine, anti-inflammatories, and topical analgesics. Again, when you're doing your pain assessment, in the actively dying patient, they may not be able to talk with you, so you're going to be doing a nonverbal assessment of pain. So how do you know, if nobody's talking to you, whether or not they're in pain? Families will ask this all the time. So if they're guarding, I tell by the furrowed brow, if they're becoming agitated and there's no clear reason, or they're starting to make vocalizations like rhythmic moanings, like it makes me consider whether or not the etiology of that is pain. There's actually a really good score that we use in dementia called the Pain AD score, which assesses nonverbal pain. And again, it looks at the facial expressions, the body language. So If you have an elderly grandmother and she's very sweet and loving, and now she's trying to hit and stalk you every time you go to her, it could be that she's confused, but it could be that she's in pain. So sometimes when I see agitation or what I think is delirium, I treat it for I treat them for pain sometimes before I treat them for agitation. So opiates and opioids. So morphine tends to be the mainstay, and morphine's an excellent medication because it can be given IV, sublingual, orally, subcutaneous, rectally. You can inhale it. Very functional. Tends to be fairly fairly inexpensive. Using a sublingual morphine concentrate to manage pain in patients who have lost the ability to swallow is how we usually manage patients at home. Most of our patients who are dying at home don't use IVs. They use oral medications to manage the symptoms, and it can be quite effective. If you give sublingual morphine, the onset of action is probably going to be as good as it's going to be in 30 minutes to an hour. If you give an oral tablet, it's going to be as good as it's going to be an hour. If you're giving it IV or sub-Q, about 15 minutes. Short-acting oral opiates at the end of life can be safely dosed every 1 hour because I'm telling you that it's going to reach its peak effect in an hour. So if it's not working in an hour, then it's probably not going to work after then. And you can dose it every 1 hour just until comfort is achieved. So once you see your person relax, you don't need to give any more. Then you take the dose that you're giving and space it out every 3 to 4 hours. Because one of the things patients and families are always worried about is, hey, at the end of life, are you going to give them too much medication? Am I going to dose them? Am I going to overdose them? Am I going to hasten death by using these medications? And I explain to them, no, because if you're comfortable and you're fine, I'm not going to give you more medication. I'm only going to give you medication until I see that comfort is achieved or you're on your way to comfort, and then I will space it out appropriately. But right now, instead of like most illnesses where you're just giving the medication to prevent the problem, and this, what I'm doing is I'm allowing your body to show me what it needs, and that's how I develop my plan. And once I explain it that way, then families are like, okay, we have control, and I trust them. I say, okay, you're not going to hurt the person that you love. So if they're fine, you're not going to give them medication. If they're not fine, you will. And people understand that. You're also going to be monitoring for neurotoxicity, because what happens, the problem with morphine is that it's cleared through the kidneys. So if your kidneys aren't working well, then you might start seeing toxic effects of the medication. So you're giving morphine, things are going well, kidneys are failing, and now the person's delirious or confused, or they're having lots of myoclonus. Anti-inflammatories are non-steroidal anti-inflammatories and steroids. So again, can be versatile. They can come in tablets, capsules, liquids. You can give it IM or IV. Incredibly helpful for bone pain, fever, and inflammation. If you got meds to the bone, love non-steroidal anti-inflammatories. Problem is that it's going to be limited use in renal failure, liver failure, peptic ulcer disease, gastric reflux, and bleeding disorders. So really, in your pre-active phase, it may be a little more difficult to use if they're starting to have some of the side effects. And other side effects profiles like hypertension, bleeding, and swelling. But at the very end of life, if this is what you have to use, then I would definitely use it. Just be mindful that if the patient looks uncomfortable, they're pointing to their stomach, it may not be, you may have to stop them. Steroids also incredibly helpful with fever, inflammation, nausea, fatigue. Remember the side effect profile that it could make. Sometimes they can get delirious with the steroids. You can get a little delirious with a non-steroidal anti-inflammatories too, but you think of more of steroids and psychosis, interferes with sleep, and then causes some of the same side effects of the non-steroidal anti-inflammatories, but you have the added bonus of getting hypoglycemic and weak if you're taking them for a long time. But again, if you're talking at the very end of life, if this is what you have, you can use these medications and just monitor them for side effects. But usually they're so far down the process that they're not going to have time to develop all of these side effects. Acetaminophen, you can give it IV, you can give it rectally, you can give it orally. It can definitely help with fevers. However, there's limited of effectiveness. And it's not going to be appropriate in liver failure and alcohol over people who are actively drinking. However, there are some people who are incredibly acetaminophen responsive, but usually at the end of life, these are less ideal. So if you have opiates primarily, if you don't, these other two can be used, but they will have limited effectiveness. Ketamine. So in places where opiates are more difficult to get, sometimes you can get ketamine because it's an older anesthetic, and it's used in that realm, so it may be available. And it can be used to treat chronic pain, neuropathic pain. And it also has new acute pain guidelines. So that's what you would need it for, because you're not managing the chronic pain, and you might be treating the neuropathic pain, but what you're actually managing is the pain of dying, which is acute, and you can give it IV, oral, nasally, and transdermally. The IV dose is using sub-anesthetic intravenous ketamine boluses, starting up to 0.35 milligrams per kilogram, and infused up to 1 milligram per kilogram per hour for acute pain. And these guidelines were based on post-operative pain, but I think these are the same doses that we're using in the active dying phase as opioid sparing for people who aren't tolerating them well, or we're not getting anywhere with the opiates. You can actually use ketamine to potentiate your opiates. So if you're having patients who you're increasing the dose, but they're developing neurotoxicity or they're having hyperalgesia, you could actually give ketamine and be able to lower the dose of your opiates and to try to achieve pain control. You want to avoid it in poorly controlled cardiovascular disease, those who are actively psychotic, and liver disease. Again, it's opiate sparing. And if they have the psychoactive effect with, so if they develop dissociation and confusion and hallucinations with ketamine, you're going to treat that with benzodiazepines and not with an antipsychotic. So that would be really important to remember, that if you're going to be giving ketamine, you got to have some sort of benzodiazepine there just in case they develop psychosis, if that means so. Ketamine psychosis treated with benzodiazepine. Managing shortness of breath. So even patients who don't have any primary lung problems, so dementia patients, patients with cancer that may not necessarily even be lung cancer, most patients at the end of life develop some shortness of breath. So if you can find an etiology, if you can find a reason why, treat it. So if they're overloaded, take the fluid off. If they are having bronchospasms, use bronchodilators. If they're having secretions, manage the secretions. The other things that you can do if you don't have medicines available right away, or even if you do, is use a fan, whether using a hand fan or electric fan, blowing across the face, stimulating the trigeminal nerve, decreases the feeling of being short of breath. And then, of course, the mainstay, low-dose opioid therapy. So I tell my patients who really struggle with shortness of breath that, look, a little dab will do you if you're really short of breath and I'm giving you morphine. I'm not giving you morphine to suppress your breath. I'm not giving you enough to cause you to feel odd. This is just a little bit to dilate your pulmonary vasculature and also to tell your brain that you're not as short of breath as you think you are. But patients who have underlying lung problems have a very a more narrow window. So you just want to make sure that they're educated about that and making sure that they're using it appropriately. At the same time, you want to avoid strong odor, smoke, or fumes. So really educate your caregivers about keeping the house ventilated and avoiding these. And then you want to evaluate for emotional distress. Because when you are actively dying and you're frightened and afraid, sometimes that might manifest in physical symptoms like pain and such as shortness of breath. And if you deal with the emotional distress, so this is why you need your interdisciplinary team and your chaplain, your social worker, to sort of talk to them about what they might be going through. So if you're talking to them and they're calming down and they're feeling better, that might actually be emotional. And then if you're experiencing periods of apnea, then death is likely in 24 to 48 hours. Terminal secretions. So this is the death rattle. So this is really, really important because this is the one thing, even if a patient is incredibly comfortable, the setting's right, everything's going well, they don't have a furrowed brow, but if the family hears a death rattle, their interpretation is that their loved ones suffered to their last dying breath, even if it's just secretions transmitted over the vocal cords making a loud sound and the patient is showing no signs of distress. If the family hears a death rattle, that's one of the last things they hear. And when your loved one is dying, I explain to my students that for the family, to the person going through it, it's like a movie, and they're going to replay this movie in their head over and over again. The families will remember almost everything, sometimes in very vivid detail, like in 3D. They'll remember the sights and the smells and the sounds and everything they felt. And so if you're going to remember that, and those memories are going to start pushing through your daily life, then if the family has to listen to a death rattle for 2 to 3 days, imagine that's the movie that's going to play in their brains forever. So what I say, this is important to manage. So, okay, Kim, so you said that this is incredibly important. How do we manage it? Well, first, most of it is secretions transmitted over the vocal cords. So you're going to move the head from side to side to mobilize the secretions. Occasionally, some patients will even turn them prone. More aggressively, I've hyperextended the neck. I've put in trumpets for patients who are morbidly obese. I lessen the amount of benzodiazepines I use because I don't want that to relax and have the tongue slide to the back of the throat. Thinking of all the physiologic ways to relieve it. You want to avoid deep suctioning because the more you suction, the more secretions, and then leads to more suctioning. So the family just remembers you suctioning out all this fluid, and the person suffered to their last dying breath, even if they didn't. You want to stop at this point artificial nutrition and hydration, because you don't want to create third spacing or any volume overload. And then the gut doesn't work so well. So if you're giving them artificial nutrition and they vomit, then the family just remembers that in the aspiration, and that's traumatic for the patient. Anticholinergic medicines. There's going to be the best evidence for glycopyrrolate. If you have access to that, 1 milligram orally, you can give that every 3 to 4 hours, or 0.2 milligrams sub-Q or IV. I often use 0.4 milligrams. I might space it. If it's really bad, I might space it every 30 to 15 minutes, but most of the time every 2 to 4 hours. If you have access to atropine, the data on atropine, plus or minus, those are the eye drops, the same atropine eye drops that you put in somebody's eyes, you can try to use to manage secretion. Just remember, it's going to come with all those anticholinergic side effects, but at the end of life, you're not as worried about those. So also myoclonus. So this is the jerking. So the family comes to you and the patient's moving around in bed and they may be jerking an arm and they're worried that they're having a seizure. Well, they're not actually having a seizure. What they're having is myoclonus. And that can happen if they have end organ failure. So these are your liver failures and your renal failures. They're laying in bed and they're having these jerking motions. When the opioid doses get really high, you might notice myoclonus. But you can also read all the list of things that could possibly do it. So how are you going to treat it? If you think it's the opiate, so you started some morphine and the doses got pretty high and now they're jerking, just if you have another option, rotate it over. If you can decrease the dose, try to do that. If you cannot do any of those things, benzodiazepines are appropriate to use at the end of life. That will calm down those emotions. It's important to educate the family about myoclonus, but you want to stop the myoclonus because, again, it's very difficult for them not to feel like it's a seizure or uncomfortable, even though it's not. But education really helps. One of the worst things that can happen at the end of life is terminal delirium. Terminal delirium and restlessness is a particularly distressing form of delirium that occurs in a dying patient. It's absolutely horrible. So it's different than the normal confusion and delirium you read about. This is actual, the patients are in agony. They're anguished, they're restless, they're agitated. They can't remember anything. They're moving all around. And you almost know, you can feel terminal delirium because when you walk in the room of these patients, you want to leave immediately. Or you feel helpless, or you have a very strong desire to give lots and lots of medicine. Like it's one of those symptoms that actually there's tons of transference. So delirium can be reversible in patients with advanced illness. So not all patients who develop confusion with advanced illness is terminal agitation. So it can be reversed in and it can even be reversed in maybe about half of the terminally ill. Because again, terminal delirium is an entity within itself. We're not talking about regular confusion. Delirium may not be reversible in the last 24 or 40 hours of life. So when it's not reversible, that's terminal delirium. It's usually secondary to end multi-organ failure. It can be actually a sign of impending death, and it can occur in greater than 85% of patients prior to death. So how are you going to manage terminal delirium? So unlike regular delirium, where your mainstay is to use an antipsychotic first, with the caveat that it increased risk of sudden death in the elderly and has all these other side effects, you might actually consider using benzodiazepines, especially if myoclonus is present, because the etiology of this delirium is different. The etiology of this delirium is death. So you're not only calming down what's happening to them physically, but then giving an antipsychotic to help with mentally. If you're going to use an antipsychotic, Haldol or haloperidol, a 0.5 milligram to 2 milligrams for moderate, 2 to 5 milligrams for severe. If you're checking, you're probably not going to be checking EKGs at this time or electrocardiograms. But if you were maybe in the PreActive phase, or you're not sure you're in the PreActive phase, but you think it might be 2 weeks, but you're not sure, then you may consider checking an electrocardiogram. And if their QTC is greater than 450 milliseconds, you might not use haloperidol, or you might stop it if you obtain another electrocardiogram if it increases by 25%. So what I explain to students and residents, because this is really hard, just get down to brass tacks. If they're delirious and you're not sure it's terminal delirium, then you might give them an antipsychotic. The antipsychotic is supposed to sort of correct the psychosis that's happening, and then if they're anxious, then 30 minutes later you give the benzodiazepine. Because if you give this benzodiazepine first, it acts in your brain a little bit like alcohol. So I'd say you might just take a person who's a hyperactive delirium and make it hypo, or if the person is a sweet person when they drink alcohol, then they'll be very quiet. If they're a mean person when they drink alcohol, giving them benzodiazepines will make them worse. If they are actively dying, then you have the option. If they have a lot of myoclonus or they're having seizures, you might go ahead and give the benzodiazepine. And then if that's not helping, then you might follow it up with the Haldol, or you might give both at the same time in the actively dying or the terminal delirium. So just remember to make a distinguish. We're going to treat terminal delirium a little different than the regular delirium that goes along with illness. For 10 to 20% of terminally ill patients, delirium may be best managed by palliative sedation or intermittent palliative sedation. So palliative sedation means sedating to the person to the point where they're sedated and the symptom has stopped, and you continue the sedation on in perpetuity, or intermittent palliative sedation, where you sedate the person until the symptom stops for a defined period of time, then lighten the sedation to see if the symptom is better. Medications we often use for palliative sedation are propofol, midazolam, or even phenobarbital. And there's some others on different protocols, but these are the ones that we use, and if you were to use them, using these ranges, you would be safe. All of these are very short-acting. The propofol, midazolam are very short-acting, so you could sedate somebody till they're comfortable, and then in a few hours attempt to wake them to see if the symptom has stopped. Palliative sedation is not the same thing as euthanasia. So when we are not actively causing death, you're sedating somebody, you're going to palliatively sedate them until the symptom stops, but you're not going to continue to increase the sedation because your goal isn't to hasten death. It's just till the symptom stops and their body goes through the natural process as though it's already going through. The unintended consequences is that they're not eating and drinking, but if they're terminally agitated anyway, they're not eating and drinking anyway. So I don't believe that it's actually making things worse or hastening their death to palliatively sedate someone who does require it, because they're not doing any of the things that are life-sustaining anyway, they're just suffering. But palliative sedation should be an option of last resort. After you have tried everything else, and also in consultation with others to make sure that's appropriate. Managing dying, the near-death awareness. So terminal restlessness has the potential to be confused with near-death awareness, which describes as a dying person's instinct and knowledge that death is near. So, and there's a really great book called Final Gift that kind of discussed this really well by Maggie Callahan and Patricia Kelly. So near-death awareness, so what's the patient doing? They're asking to go home, and they may already be home. They're trying to get out the open window, like they keep sitting up in bed and trying to go somewhere, and you're having to let them know, no, there's no place to go. They're like, no, take me home. They have faraway looks, or they're looking at somebody in the room that you obviously can't see. They start talking to family members that have gone on before, and they tell you they have a feeling that death is coming. This does not require treatment, but families and staff need education about it because it can be very distressing, because even if the patient's not upset about it, the family may see the patient leaving them. So they're still in the bed, they're still talking, and it's like they're going away from them. And that can cause a lot of family distress. And many families will come to you and say, make this stop. Not because they're upset about the near-death awareness, but they see the person leaving and they want you to make them come back. So this is a really good time to explain to them that this is a natural part of letting go. But sometimes the experience can turn into death anxiety. And we see this a lot with our soldiers coming back from wars, or people who have gone through traumatic experiences or have lots of guilt and may be concerned about what the next phase or what the next step is after death, and they develop anxiety around it. In this instance, the near-death awareness that is now turned into death anxiety is appropriate to be treated with benzodiazepines, and that actually may be helpful. And this, again, is a place for your spiritual health clinicians and chaplains that may be able to get at the reason for the death anxiety in a way that medical personnel may not be able to. The families may not share this with you because it's not appropriate. You know, they see you as the doctor. They're like, you're not going to want to know what I did in war, or what happened to me when I was a child. But they may feel more comfortable telling the social worker, the volunteer, the spiritual health clinician, or chaplain. Social support is key here. Some patients are just agitated, where they're just restless and they're kind of all over the place and they're pacing and talking and crying, but they're completely, you know, they're paying attention, they're not confused, they're just having a lot of nervous tension associated with anxiety, fear, and mental stress. So in this situation, when they're agitated, you're going to assess for social isolation. What's happened? They may have lost their social status, they've lost friends and families, really delving into what can we do to sort of help you tie up the business of life? What is it that you need? What are you lacking? How can we help you reestablish meaning? How can we help you reestablish dignity? And then for patients who are, particularly patients who are nonverbal, I tell families, specifically for my patients who have cognitive problems or dementia, that they sometimes become like mirrors. So if the caregiver is happy or you're happy, then the patient expresses happiness and they're calm. If you're upset or the caregiver is upset, then the patient may express agitation because they're mirroring back to them what you're showing. So if the caregiver is stressed and the house is chaotic and the patient's agitated, we need to unstress the caregiver and make the house less chaotic. And the patient often, many times, will calm down. Managing dying and physical symptoms such as wounds. So this is really difficult because you have a lot of caregivers who are doing everything they can to care for their loved one, and they're turning them and they're doing all the right things, and then all of a sudden they get a wound and they're like, what happened? They say, why? Either I failed or the healthcare providers have failed me. They've let my loved one develop one. So when people are actively dying, it's important to let your family know that there's a possibility that the underlying tissue of the skin could die because the blood flow gets redirected to important things. So I would say the body is incredibly efficient. If you're not doing well and there's only a limited supply of blood, it's going to give it to your brain, heart, and kidneys, things to keep you alive, and the gut and the skin kind of get the short end of the stick. So during the active dying phase, underlying tissue dies due to low perfusion that causes severe dysfunction and failure of other organ systems, which then leads to skin failure, and they can get Kennedy or terminal ulcers. So what do you do in that situation? Number one, let the families and caregivers know it can happen. Number two, tell them it's not their fault. Number three, manage the pain. Limit bandage changes. Use whatever bandages you can to change only when there's strike through. That means you see secretions on the bandage. Decrease the odor. Metronidazole, you can crush it in tablets and put it in the wounds. Other things, other odor-absorbing items in the room, keeping the rooms well ventilated. Decrease infection and bacterial burden. That's why we use the metronidazole. Manage any bleeding. and maintaining quality of life and still encouraging therapeutic touching of the patient. So coming back, rounding back to artificial nutrition hydration, because this comes up. Artificial nutrition and hydration during the active dying phase does not lengthen or improve quality of life or provide comfort. So, okay. And I think most of us agree with this, so why do we continue to do it? Oral intake for comfort is appropriate, so I do encourage family members to feed their relatives, because feeding is nurturing, if a patient can tolerate it. It is normal for patients to lose the desire for oral intake. This should be explained to families up front, right? If they go into this knowing with the expectation that during the normal dying process, the part of their brain is going to tell them not to eat, that part's going to turn off, and that's okay because they don't handle the food anyway. So I say, instead of it being a negative, I actually turn it into a blessing. I said, the human body's amazing. By the time you are no longer able to eat, the part of your brain that's telling you to eat actually turns off. So you're not having to suffer through being hungry and not being able to eat. And people go, oh, so yeah, so this is normal. This is normal. This is what's supposed to happen. A trial of hydration may help distinguish between a reversible delirium and a terminal agitation. So I say that at the end of life, you got to figure out where you're going to draw your line in the sand. If I have a family or a patient that says, doctor, I understand what you're saying, I just need some IV fluids, I just think it might help. If they're in a monitored setting, I might say, you know what, okay, we will do a time-limited trial. But let me tell you how this will work and what we can do. I'm going to order the fluids, and if I see these symptoms, then I will stop them. Because what you don't want to do is give the family the choice and then ask the family, hey, should we stop them? And now they feel like they're the ones that hurt their relative or took something away. Because artificial hydration and nutrition are medical interventions. They're not food. They need us to order them. So if I'm responsible for ordering them, then I am also responsible for stopping them. And I don't ever want to put the family in a position to believe that something was discontinued, that I put all that burden on them. If it's medically appropriate, I tell them that I will do anything I can to help your loved one. I will do anything that I believe that is neutral, that will not harm them. But if I believe that they're being harmed, I will have to stop it. And most people accept that, if that makes sense. Gastrointestinal function and ability to manage IV hydration fails as the body is actively dying. They just do. So everybody needs to know that up front. Administration can cause shortness of breath, aspiration, and volume overload and lead to unintended suffering during the actively dying phase. So not the pre-active phase, but during the active dying phase, in the last 24 to 48 hours, it's very appropriate to stop these interventions to make sure they don't have a bad side effect, because that's a terrible thing. That is a very terrible death, aspiration at that stage. So managing the dying, thinking about the caregivers, what do you say to them? So education for families concerning the active dying process is very important. You don't have to burden them with it, but gently while you're in the course of taking care of them, as they're seeing different things arise, they may not ask you questions, but you might see questioning in their eyes. Go ahead and tell them what's normal during the exam. Oh, your loved one, his skin is very cool. We were expecting this. Oh, do you see this lacy rash? We were expecting this. The reason why is because of this, this, and this. Oh, I see that he's not swallowing as well. We were expecting this. Let me show you how best to make sure his mouth stays moist. Is it okay? Let me tell you how we're going to care and manage this symptom. And this might come next. So I think it's a way you can educate people without sort of hitting them with it like a Mack truck, but sort of educating them through the process, giving them maybe the next stage. You don't have to give them all the stages for the next stage they should be looking for, but more importantly, educating them on how you're going to manage that stage. So just don't tell them, hey, he's going to get short of breath. You got to tell them, he's going to get short of breath, and this is what we're going to do about it. And he's going to have secretions, and this is what we're going to do about it. Encourage the family to be present. Make spiritual health clinicians or chaplains or social workers and other support personnel available if you have the option. Be available to answer questions, and also anticipate and tolerate family doubt. You know, so they may say, doctor, are we doing the right thing? Maybe we should go back to the hospital again, or maybe we should try this or try that. Listen with an open mind and an open heart, and then just take them back through everything that has happened and explain, you know, why you're concerned that that may not be in their best interest, and what you can give them instead of what they're asking for that might be in the patient's best interest. But just your openness to be able to hear it can be very helpful. Also, try to anticipate the family needs. So what are the families concerned about when the loved one's dying? They're concerned they're hungry. And why do they want to feed them? Because feeding's nurturing, and that's a way to connect. And we love, you know, around our family table, you know, when we're all eating together, or, you know, if I'm cooking for my family, I feel like I'm, you know, doing something loving. So what you would need to coach somebody like me through is, Kimberly, you can't feed your husband or your son. So what are your other ways you can nurture them? Thirst, are they thirsty? Again, I have a desire to nurture my loved ones. So show me how to moisten the mouth without choking them with water. Show me what the other alternative is. And just telling me that they're not thirsty and hungry isn't going to work. Explaining to me other ways to manage that, and to explain to me that I'm okay, and showing me is more helpful. Speech, I'm not able to talk, so I have the need to communicate with my loved one. So promote to me or explain to me that they can still feel my touch. I can watch for nonverbal communications. I can still talk with them. They can still hear. I can still play their favorite music. I'm worried that my family member, they can't see me, because what the family wants to be is to be seen. Say, so no, I don't know if he could see. I often say, when they're worried about, can he see me, can he hear me, I will say, I don't think he can see or hear the way you or I see or hear, but I believe that he feels your presence, maybe in a more spiritual way. So I would encourage you to hold him or her, hold their hand, and speak to them, just as though you were speaking normally. And that can sometimes be helpful. Touch. The family's concerned whether or not it's okay to touch their loved one, because what they're trying, the need is for, they want to feel that presence. So if touching is not appropriate, like maybe like an end-stage renal failure, the skin can be really sensitive, or they try to touch their loved one and they moan, then help them try to focus on non-physical connections. You know, being silent, being present, praying, all the things that can bring you together if touch isn't possible. And then also show them appropriate ways of touching, the palms of hands, the soles of the feet, the top of the head. Avoid the rubbing of the arms and things like that that can sometimes pick up pain. Information, when you're talking to caregivers, to guide them through the process. So in impending death, when death is within hours, this is when you might want to discuss the death rattle, or that there may be periods of apnea or pausing. They may start to breathe with their with a lot of mandibular movement, and that's really distressing for families. Preparing them for that and having a plan for that. Talk to them about what happens to the skin, because their loved ones don't look the same, and that's very frightening. And they're often feeling for a pulse, so sometimes they could smooth the lack of their radial pulse as they're going through this process. Signs of death. So what happens when death happens? So you're not going to be at the house all the time, and maybe you don't have staff there that can be all the time. The family is attending the death alone. How do they know when their loved one has died? How do they know when to call? You explain to them that the pupils are fixed, the skin becomes waxen, all the muscles relax. That's why the eyes stay open, the mouth kind of goes open. They may release their bowels or body release fluids, so prepare them for that, because that can be really distressing. And have a plan, like who's going to change them, what do we do if that happens. And then there's a loss, of course, of heartbeat and respirations, which everybody understands. But I think letting them know that the skin may change. I tell sometimes it's like, you kind of know, because it's like the light goes out. So the take-home summaries are points. Prognostication for patients who are at the end of life is an important skill. And so if you're going to practice palliative care, if you're just going to be a physician, no matter where you're going to practice or what you're going to do, understanding this is a skill and it can be learned, and it's important to know. Symptom management at the end of life requires an understanding of the active dying process. So you have to know what dying looks like in order to manage the symptoms appropriately and be flexible and be nimble. Each patient will be different and they will need tailored treatment plans. It's important to recognize and address the existential distress of dying. So you can address all the physical parts you want, but if you do not address the existential distress of the dying patient, you will not get them as comfortable as they need to be. And it doesn't mean that you have to do it, but you need to know who you can employ to assist you. Near-death awareness is a normal part of dying process. It doesn't require treatment, it requires support. That's people in their minds trying to work it out. In every culture all over the world, there's some sort of near-death awareness, and surprisingly very similar. And families need education on the dying process. Again, you don't have giving them written literature if they ask you what's going to happen, but sometimes just gently, as the dying process is occurring, identifying things and explaining that they're normal, but also explaining how you're going to manage the symptoms that you may find distressing in a gentle way that allows them to receive the information. All right, so I come to the end of the lecture. Thank you so much if you all have any questions, but I greatly appreciate your time.